So in this video, we're going to talk about lumbar anatomy and with a focus on practical anatomy. So instead of focusing on attachments, exact attachments, and of every little structure, we're going to talk more practically about how does anatomy relate to how you can be a better clinician, evaluating your patients and understanding how anatomy might relate to your exam and intervention. So the first thing to look at is just the skeletal system. And so if we look at the overall skeletal system, I think the first thing that's really important to point out about the lumbar spine is when you look at it in relation to the whole skeleton, what we see is below the lumbar spine, we've got the pelvis, okay? And the pelvis is a very stable structure. You can see that the bones are much bigger than they are at each individual lumbar vertebrae. The SI joint is very congruent and stable. So if we look at it from the backside, we've got a lot of bony contact here. There's not a lot of movement that's supposed to happen at the SI joint. So these bones are very stable, where the hip joint is supposed to be very mobile. SI joint is supposed to be very stable. Then the lumbar spine and the pelvis should also be stable. Well, the lumbar spine kind of needs to be stable, but it's trapped in between this large bony area. And then right above it in the thoracic spine, we've got the rib cage. And the rib cage creates a lot more bony congruency when you think about this extra bone here that articulates with the vertebrae in the thoracic spine. It can create more stability in that region, in addition to maybe the facet orientation in the thoracic spine. But what that does is when you hear about core stabilization, and that's such a common intervention used in managing low back pain, when you think about core stabilization, that's largely why that's the case, is because you need to compensate for this lack of natural stability in the lumbar spine. You have natural stability in the pelvis, natural stability in the thoracic spine, and you don't have that natural stability in the lumbar spine. And so the body moves through the path of least resistance. If you're going to go pick something up, if you're going to go just use a shovel or pick up a laundry basket or bend over to do anything, really, the body's going to move through the path of least resistance, which is right there in the lumbar spine. And so it's no wonder that lower back problems are so prevalent. People wear them out unnecessarily. So that's the first thing that's important practically to look at when it comes to lumbar anatomy, is its overall relation to its neighbors. Now, if we look at one individual vertebrae, what we're going to see is that the body of the vertebrae is large. So, we're going to have the width here of the vertebrae is wider than it is tall. And the reason for that, the reason for this big, broad, body of the vertebrae is so it can handle more compressive loads. It can distribute those forces across a larger bony surface. This over here being the transverse process, spinous process, the pedicle, the lamina, the spinal canal, and then the facet joints right here. Now, when we look at the facet joints, they are primarily oriented in the sagittal plane. So the motion in the lumbar spine that has the greatest degree of freedom is in the sagittal plane, flexion and extension. If we go back and we look at the whole skeleton again, if you look at how the facets come together here, you can kind of visualize that if a vertebrae was going to try to rotate right and left, that these two bones are going to run into each other. They're going to bump into each other, and there's not going to be a lot of rotation available the way that those facets are oriented. So there's only a couple of degrees of rotation per vertebrae, and so when we're assessing range of motion in the lumbar spine, we are rotation is usually a full thorax assessment rather than just lumbar rotation. So that's an interesting or an important point to point out about those facets. While we have the whole skeleton here, I think the other thing that's important too to look at is when we look at this canal right here. This is where the nerve roots exit. So if we look at this one vertebrae in isolation, you can see that the superior vertebrae, this is the inferior portion of that foraminal canal. And then up here is the inferior portion. So the vertebrae that sits above this is its superior portion will sit up here and create this foraminal canal. So when we put those two together, again, it makes this hole right here. So that brings us to the disc space. This would be called the inner body joint right here, where there would be a disc. So if a disc loses height, then a couple things are going to happen. One, this foraminal canal right here is going to get a little smaller. And so the nerve root may not have quite as much room to exist in that hole when the disc height narrows. The other thing is that these facet joints can maybe take on some additional compressive force if there isn't as much separation between these bones from the disc. So that's an important note to make about that. When it comes to the transverse process and the spinous process, they primarily act as attachment points for muscles and ligaments and things like that. A muscle needs some mechanical advantage to move our trunk and whatnot and to create stability. And so it needs bony prominences that extend out from the body in order to create leverage, to create motion, or to create stability in these segments. So now if we bring in connective tissue, we've got in the front here, we've got the anterior longitudinal ligament. That's a big, broad ligament covering the front there. It's going to check extension, kind of helps prevent disc material from bulging anteriorly too far. If we look at its counterpart, the posterior longitudinal ligament, we'll need to remove a vertebrae here, and right here you can see the posterior longitudinal ligament. Now, something that's interesting about that ligament is if we look at the disc, I'm going to go ahead and hide that so we can see the disc easier. When you hear of somebody that has a bulging disc or a protruding or a herniated disc or somebody that just has sciatica, well, typically somebody that has sciatic symptoms, it's usually one-sided. It's traveling down the right or the left leg most of the time. Well, if that sciatic problem is coming from a bulging herniated disc, usually what ends up happening is this nuclear material in the center of the disc. That's the part that's a little softer, it's a little bit more gel-like, and it has the capability under compression to start and bulge. Now, when it starts to get compressed and move posteriorly, like so, it can run into the posterior longitudinal ligament, and then that protects the spinal cord. So you got the spinal cord running right behind the posterior longitudinal ligament. Might be a little busy here, but you can start to see that the spinal cord roots down here. And so that posterior longitudinal ligament can act as an extra protectant to that. So when disc material starts to move backwards into the posterior longitudinal ligament, then it can get pushed off to one side and then affect just one nerve root versus the whole spinal cord. So that's an important note to make about that particular ligament. Now, if we look at the ligamentous makeup of the disc, you can see that the annulus surrounding the nucleus has fibers moving in different directions. There's approximately 15 to 20 layers of ligaments surrounding the nucleus to hold that in place. Now, when a disc gets compressed, this softer nuclear material pushes outward against the annulus. And then the annulus pushes back and checks that motion or checks that compression, and it creates pressure inside of the disc, and that creates a shock absorbing mechanism. So, the fiber orientations going in different directions can also help check rotation, inflection, extension, different directions of forces. So those different directions of fibers are meant to check various motions that might occur throughout the lumbar spine. So through repetitive motion and repetitive compression and stress of a disc, these annular layers can start to become disrupted. You can start to get an annular tear or an annular fissure, and it starts to create an opportunity for nuclear material to start moving into these tears and into these worn down, stretched out fibers, and it slowly starts to work its way and find its way out and create bulging of that outer annulus. It's important to note too that the inner part of this nucleus and the inner part of the disc does not have a nerve supply. So you can start undergoing a lot of pathological changes within inside the disc and you wouldn't know it was happening. It's when you get more to the outer rim here that you can start getting nerve innervation and pain. So that's another important note to make about that structure. Right here, you've got the facet joint capsule. So it just creates an encapsulation of that zygapophyseal, that facet joint, to create stability there. And then you're going to have a bunch of other, smaller ligaments that are going to connect the bones together. I mean, you've got the inner spinous ligament here, the inner there should be an inner transverse ligament here. Again, just creates passive stability of the vertebrae. But again, if we go back to this idea of bony stability above and bony stability below, you've got these ligaments that are passive stabilizers that are trying to make up the difference, which leads us to muscle. When we look at muscle tissue, the lumbar spine has got multiple layers of muscles. If we go to the deepest point, we're going to have very small muscles, these interspinalis and these intertransversarii lumborum muscles here. So you're going to get these small muscle groups that are very deep in the spine and acting to create, proprioceptive information and stability of the spine. If we add another layer of muscle, the quadratus lumborum, we've got multifidi. So as we add more layers of muscle, instead of spanning, like where this, you'll see a muscle, just one muscle spanning only one vertebrae. It's connecting just one vertebrae. When we add a layer, like the multifidi, then its fibers are gonna start to span more than one vertebrae. So when we continue to add, the quadratus lumborum spans a larger area. As we add more muscle, again, we've got long sweeping paraspinals here. From the front, we've got the transverse abdominis. That's kind of a popular muscle to hear about when it comes to core stabilization and trying to elicit a tonic endurance type muscle that's meant to create stability. As we continue to add muscles, we get into more phasic muscles that are designed to generate motion. So the rectus abdominis really is, sure, it can have a stabilizing role, but if you're going to sit up out of bed, the rectus abdominis needs to be there to lengthen and shorten, to be a phasic muscle, to create motion of the trunk, where these deeper muscles are going to be more involved in proprioception, stabilization role. From the front, you've got the psoas, you've got the iliacus, making the iliopsoas common tendon. So they create, that's a muscle that crosses many articulations in the lumbar spine, the SI joint, the hip, crosses a lot of different articulations. So that's a muscle that can become tight and can become a source of pain in the lumbar spine. So when you think about adding all the layers of muscle here, and then the lats, these big muscles here, and the thoracolumbar fascia right here. So yes, there is a lot of potential for stabilization around the lumbar spine when you think about all the layers of musculature. However, when we go back to the concept of the body moving through the path of least resistance, when the brain, here's an important point to make, when the brain decides how it's going to perform a task, bend over and pull a weed out of the ground, bend over and pick up a laundry basket, bend over to scrub a bathtub or whatever it may be, the brain makes decisions based on energy efficiency, energy conservation. So when you think about adding in the glute max, the lats, the glute medius, when you think about bigger muscles around the lumbar spine, the brain says, well, these are expensive muscles to use. If I'm just going to bend over to pick up a laundry basket, if I'm going to engage, if your body naturally said, okay, let's go ahead and turn on some of these deeper stabilizers, transverse abdominis, multifidi, and then let's really fire the glute max when it comes to driving our hips forward when we lift up that laundry basket. We don't naturally see people move that way. We see them kind of flex at the lumbar spine, and not ask this pattern of stabilizer muscles in the core and these big mobility muscles in the hip to work. It's expensive to do that. And so we end up just kind of casually bending through the lumbar spine. There are studies that show that the lumbar spine will flex forward somewhere between 3,000 and 5,000 times in a 24-hour period. So what that would suggest is that we're not doing a very good job at stabilizing the lumbar spine when we have to bend down to do certain tasks, that we choose to just flex and move through the lumbar spine. Now, when you think about that concept, if we get rid of all the muscle again and we look at the vertebrae again, or if I add the disc back in here, well, if we flex, when we bend forward, the vertebrae come together like this. They compress in the front anteriorly, and then it stretches the structures in the back. So the facets kind of open up, and you compress in the front. Well, if I compress the front of this disc, well, this material is going to be forced to be pushed backwards. So that's why when you see somebody has a bulging disc, it's almost always a posterior or a posterior lateral disc herniation or disc bulge. And that's why we flex and we flex and we flex and we flex. And that disc material is just abiding by the forces applied to it. Just simple physics. So that's where it's important for these muscles. Not only is it important for these muscles to be strong, but they need to be well coordinated. They need to have good endurance. The coordination part is where physical therapy comes into play, where we evaluate the strength, the endurance, but also the motor control, the ability for them to turn on certain muscles at the right time and create proper stabilization. These muscles are not supposed to be contracted heavily all the time. They need to rest. They need to turn off. So when do they turn on? When do they turn off? That proper motor control. So that's where physical therapists can come into play, is assessing that portion of the lumbar spine. It's motor control and strength and endurance. So that gives us a basic overview of pertinent lumbar anatomy as it pertains to things that are important in the clinic. And as you go through your exam and treatment, then it's important to just kind of recognize some of those phenomenon and keep that in mind as you are making treatment decisions. So that will wrap up that video, and hope that was helpful, and we will deepen that in our other videos later, but that will be a good introduction to start.